So good evening, everyone. At the outset, I would like to extend my sincere thanks to the Sonosite India for coming forward to organize this 4-day session to kind of discuss and share several of our thoughts in relation to the current situation and the clinical scenario that has the challenges that has been posed to us recently. Thank you very much for doing this, giving us this platform to share our thoughts. And I'm extremely happy to see all the executive committee members of the Academy of Regional Anesthesia of India, an organization which is striving hard to make safe practice of regional anesthesia across this country. Today, the topic which we are going to discuss will be on the personal protective equipment, an Indian perspective. I just thought it's pertinent that I do discuss few aspects of the current scenario. It is extremely unfortunate that we have been challenged by a virus and has completely changed the way we live. However, several lessons have been learned in the process. And though it is unfortunate, it is inevitable, and hence it becomes imperative that each one of us as a healthcare worker and provider, we need to have clear strategies for the next few months. The way the pandemic has been described, so nobody knows when it will come to an end, but it is clear that it's another 6 months to 9 months, and even some predict up to 1 year. There are going to be surges and there are going to be suppression, and many of the experts say that there will be 3 surges that can happen. Every surge followed by a suppression phase, and again a surge, and again a suppression. So which means it becomes very vital that we get prepared for the perioperative care of patients. And the minute the lockdown is taken out and things are eased, there is a very high possibility that each one of us, probably in a week or 2, based on which part of the country we live in, we may have to start doing elective procedures. So, and when we go into this mode, it becomes a big question mark with each of us. Is this patient a possible COVID? What are the precautions that I need to take? How do I protect myself? How do I protect my healthcare workers? And how to run the institution for another 6 months with these challenges? Hence, this particular topic becomes very imperative and important. And as all of you know, that this small virus, which originated in Wuhan, though there are several theories on how it came, but primarily, to give a small perspective of it, it is basically from the bat that came to the animal pangolin, which is a wild animal, which is not part of the food chain, of a human food chain, but it's something which supposed to be very delicious, and it is consumed by the rich Chinese. And it is this pangolin which is thought to have spread the virus from that animal to the human being when he consumed it. Initially, it was thought that human-to-human transmission might not take place, and there was a kind of complacency which has resulted in a huge price that we are paying now. So now we know that this virus, which was part of pangolin, which entered the human, and which is not part of a food chain, hence the protein that is present in this virus, a human has never got exposed to it. So no antibodies, no medicine, no vaccine, and that is why this virus is producing such a big challenge. And also it's pretty aggressive and contagious. So this has become a global problem and a global phenomenon now. Now, as we move on, how does, as a healthcare worker, when the lockdown opens, what are the important criteria that we take into consideration? How does this virus spread? So there are 3 important ways that it spreads. Number 1 is by direct contact. Number two is by the aerosol and the droplets. As we know that the droplets and aerosol, the difference is an aerosol is a particle which can be present in the atmosphere when a person coughs uh, for at least 30 minutes, sometimes to 1 hour. So this is just to show the virus, and this is the electron microscope picture of the virus where you see the spikes. And the green color, what you see is the protein that is present in the spike. In fact, we are trying to produce the vaccine based on the protein that is present in this spike. Now, when you cough or sneeze, so we have droplets and we have aerosols. Droplets settle down faster to the ground, whereas an aerosol, which is generated, stays, as I said, for roughly about 30 minutes. So now one mode is direct contact. Next thing is because of the droplets and the aerosols that are produced. And the third one is these droplets and aerosols, when they land in the vicinity of the person who coughed, especially in the fomites, it can stay for a long time. So it has been found that if it is a glass, plastic, stainless steel, it can survive for roughly 2 to 3 days. But if it's a cardboard, it's roughly about 3 hours. So based upon the object on which it falls, it lives for a long time. And if you go and touch that particular uh, fomite, then you get infected, and then you move your hand which touched this glass door or the door knob, and then you go and touch your nose or mouth or the eyes, then the aerosol, the viral RNA enters inside your body and you get infected. So now the challenges are, we have to take care of the droplets, we have to take care of the aerosol, we have to take care of the fomite, and we have to see that we don't directly touch a patient when they come in. So these are the four challenges. And if we address these four challenges, then the, the protection that we offer to ourselves becomes complete. Now, the next question now that is asked is, should everybody wear an N95 mask? This has been the buzzword across the globe. But we also know that N95 mask production is inadequate. Now, so when actually the lockdown opens and when you start getting patients inside, what should be our strategy, or what should our hospital decide, or policy that we need to do? Now we have in India, three types of masks are available. One is a cloth mask, like what you see here. So is there a role of cloth mask? Answer is yes. Who will wear a cloth mask? A cloth mask is worn by all the individuals or all the citizens, all the people of this country. So when the patient comes into your hospital, first do a screening test. Patient and the attender get a screening test done, see if they've got temperature. If they've got a temperature, you move them to a fever clinic. If they don't have a temperature, before you allow them inside, make sure that all of them wear a cloth mask before entering your campus. This is mandatory. And the reason is, we are very concerned about asymptomatic carriers or pre-symptomatic patients who have come for an incidental surgery. So one basic protocol that we need to establish is, on arrival, before allowing a person into a hospital, they have to be screened for temperature. There should be a provision for them to wash with soap and water at the entrance. Then the sanitation, like the hand sanitizer, to be applied, and a cloth mask has to be applied. And only then they enter inside. So there is a role for cloth mask. And this should be the protocol that we need to draw for every person who is entering into the hospital, including patient, attender, OPD patient, OPD attenders, all the healthcare workers. They need to have this protocol, basic minimum, to enter inside the hospital. So that's number one. Number two, now, what is this? This is a very, very important slide. and I wanted to emphasize on this three triple layered surgical mask. So current recommendation across the globe is all the healthcare workers, like when we lift the lockdown, all the healthcare workers working in our hospital should basic minimum have a three-layered the face mask, three-layered surgical face mask. What are the three layers? The first layer that you see is white, white in color. The second layer that you see is the filter, and the third layer you see is the colored one is the blue. So the first layer, the one which is on white and the one which is in blue, are made up of non-oven material. Whereas the one in the center is made up of polypropylene, and that is the filter. And we need to instruct, we need to educate, we need to instruct everybody who is wearing the mask. The white layer should be the one which will be touching the skin of the face, number one. And the blue color should be facing outside. The white color layer is the one which is a moisture absorber. So the secretions that are coming out of the nose and the droplets, it's all absorbed by this non-woven white layer. Then you have the filter, and the third one is again a non-woven layer, and this is water resistant. And when water is splashed on it, it cannot seep in. So this is a surgical triple layered mask. This should be the basic minimum protection that we need to give to every healthcare worker in the hospital, including a sanitary worker, a stretcher boy. This is the basic mask that you need to give. And the third mask, that is what we have been speaking about, is the N95 mask. Now, based upon the previous studies which have been done on seasonal flu, over the years, it has been found that N95 mask, should it be worn all the time, or should it be worn at a time when you're in close contact with the patient, or when you are involved in an aerosol generating procedure? So the several studies which have been done in the previous years, based upon the influenza virus, it has been proven that N95 mask is superior to a three-layered surgical mask, and it has to be used by all healthcare workers who come in close proximity of a patient, like the surgeon, the anesthesiologist inside the operating room, or when they are performing any aerosol generating procedures. And this N95 mask becomes mandatory for all the surgeon and the anesthesiologist who come in very close contact with the patient. Now, one of the confusing factors have been the various nomenclature that has been used. N95 is the US nomenclature for N95 mask. In Europe, it is called as FFP2. In China, it is called as KN95. In Australia, it is called as P2. In Japan, it is called as DS. And in Korea, it is called as first class. So now, since the multiple vendors in this country are importing these masks from several places, several countries, we should be clear with the nomenclature. And KN95 is the one which is available freely in India now, which is imported from China. So a KN95 is equivalent to N95 mask. Now, this N95 mask or the minimum, once the lockdown opens and elective surgery start, I think we need to recommend this for all the doctors who come in close proximity. So all the patients have a cloth mask. All the healthcare workers working inside the hospital will have a three-layered surgical mask, and the doctors and probably the HDU, ICU nurses who come in close contact with the patient should have an N95 mask. And the issues are the N95 mask is extremely uncomfortable to wear for long hours. So we can take a decision of using it when you're in close contact, and the rest of the time you can go for a three-layered surgical mask. So these are the tabular columns which are given for the various one, that you know that the surgical mask can filter any particle that is more than 3 microns, whereas an N95 mask can filter 95% of the particles more than zero point 0.3 microns. You also know that there are two more masks are available. One is N99 and another is N100, where N99 indicates 99% of particles more than 0.3 microns are filtered. And when you say N100, 100% of particles above zero point 0.3 microns are filtered completely. But most of the times, though the virus, the aerosol is very small, the movement of that aerosol and the movement of the virus is through a Brownian movement. And hence, that is why even a surgical mask is supposed to be good when you are slightly far away from the patient rather than an N95 or a N99 or a N100 mask. Now, to make things comfortable, we have the elastomeric respirators, which are available now. And it's available, but at a premium in this country, costs about 6,000 rupees. And we have to replace the cartridges. The advantage of these N95 elastomeric half-face respirators are it is much more comfortable to wear with ease of breathing and better than the N95 masks, but offers similar protection with more comfort. Now, in Indian scenario, like we have to think of all the doctors, anesthesiologists working in several parts of the country who may not have an access to the N95 mask all the time. So one recommendation, so what I would want is that everyone has to clearly understand the logic behind using this mask. What are we dealing with and what is the best that you can do based on your circumstances and your infrastructure. So several coveralls are available now, and I would want it, for example, this coverall which I show is we have been using in our hospital. It cost 130 rupees. And this is a very nice fabric, which is water resistant, which has got a central area where it is visible. It's like, you see how it is worn. And I would suggest that in case if you're not able to access to N95 mask, one of the good options would be to have the 3-layered surgical mask. Maybe we can wear 2 of them. On top of that, we can wear this face shield or a face mask. So this gives a great protection for the hair, eyes, mouth, nose, and it comes and then rests on your shoulder. This is a good improvisation that we can make for the Indian scenario. As I said, it costs 130 rupees. And if you are people who can afford it and in centers who treat COVID patients, which I think Hetal will be speaking about it. So we go for the PAPR. So I'm not going to speak much on it as Hetal is going to speak on this particular aspect. And before I complete, there was a question which came to me on how, though it is not related to PPE, they were asking about filters that we use in every patient now. Since every patient now we consider as a potential COVID patient, it becomes imperative that right from now on, every case that you do, whether it is regional or general anesthesia, you have to have clear strategies. And what we have been following in our institution has been, because on every day, even now, in spite of lockdown, we have fractures and injuries which are coming in. We roughly operate 20 to 25 surgeries every day. And hence it becomes imperative that we have started following certain protocols so that we will strengthen these aspects as the lockdown gets open and we get more patients. So as far as the filter is concerned, we use a HME filter, HMEF. It's just not a normal HME with filter. Several companies produce this in India. It costs about 130 rupees. So it is mandatory that all the patients, we put this HMEF, which is attached to the minute it started right from the time you start your putting the mask on the patient, that it is connected to the HME. So not even one breath enters from the patient to the circuit and to your anesthesia machine. And to be on the safe side, although it is mentioned, it is enough that you put a HMEF filter on the expiratory side, but we, for sake, because it's available today, because we can afford, and it costs only 130 rupees, we put it in both the inspiratory and the expiratory limb, for the simple reason that if somebody gets confused, instead of putting on the expiratory limb, they can put on inspiratory limb and the machine gets contaminated. So just to avoid that confusion, so we put a filter HMEF both on the inspiratory and the expiratory side. And also, before I conclude, apart from the personal protective equipments that you have, which we spoke in length about the mask, then the other things are very vital, is the goggle, then the coverall, the face shield, gloves. Always have 2 gloves when you're going for aerosol generating procedures. And I'm sure that both Hetal and later Dr. TVS, who is going to speak about in doing a potential COVID case, is going to speak on this. But for us, the aerosol generating procedure as an anesthesiologist has been predominantly during the process of intubation, then manual ventilation, extubation, and at times then when you want to change the patient from supine to prone position. Supine to prone position, so there is a possibility that we need to be careful. So this box, which I'm sure that in plenty of institutions, they have made improvisations of this intubating box. We have made it a part of our general anesthesia for all the cases we do, and it has got it is made up of acrylic, and the height of this is about 75 centimeters, and the width of it is about 60 centimeters, and this is extremely comfortable to work, and the 75 centimeters allows you to use a bougie in difficult intubation. And one advantage is, more than the personal, apart from the personal protective equipment, this becomes a standard of practice in decreasing the aerosol generation or getting contaminated because of the aerosols that are generated. So this box is placed on the patient, and the whole of the head is within the patient. So there are 4 arms, working arms that are coming in, 2 of the anesthetist, 1 of the anesthesia technician, and through the other arm the circuit comes inside. The disposable sleeves which are attached to it makes it a completely sealed zone, and after the procedure is over, during the process of decontamination, these sleeves can be removed off. But this is a great improvisation because these sleeves allow us to work with freedom rather than gloves which are attached to which you see in a few other boxes. And this box, on the top of it, it has got a port through to which the central suction is attached. So as the aerosol is getting generated, so the central suction continuously sucks off this droplets and aerosols. And we have made it a policy that once the process of intubation is done, this box and the central suction is left in situ for 15 minutes for entirely to get sucked off before we decide to take it out. So this is after discussion with several units which use it, 15 minutes supposed to be a good time to remove off all the aerosol. And the same thing we do it during the process of extubation. And one note of caution, the minute we intubate, before we ventilate, make sure that the HME is attached. If the HME is not there, then you have to clamp the endotracheal tube to prevent the aerosols from coming out, which I think it's a standard procedure discussed in various webinars. But I strongly recommend all the anesthetists who are going to give general anesthesia henceforth, when the elective cases started, until at least 6 months to 9 months, we should have a good stock of HME filters available. So the minute you intubate or when you want to ventilate, don't do it without the filter, in spite of having a good PPE on you. And one more thing is, when we use this chamber, all the contaminated parts, since we are wearing 2 gloves, the external glove is removed off inside the box itself, and the laryngoscope which is used, if it is not disposable blade, then it is all that we used it is immediately put in a sodium hypochlorite solution for decontamination. So this needs to be followed religiously, because intubation is a process which we have been doing for ages, and which we have not thought so much about it during the process of intubation, it becomes mandatory for us to unlearn what we have been doing and to learn new things, so that it becomes a norm henceforth for every case that we do, so that we don't breach the protocol at any point of time and in any case. So one breach of protocol can result in we getting contaminated and the healthcare workers around us getting infected. One more small point before I conclude is when you do the process of intubation, please switch off your air conditioner. Though it is recommended that it has to be a negative pressure operating theater, in vast majority of the operation theaters in India do not have a negative pressure facility. So positive pressure is fine. And the guidelines currently is you need to speak to your maintenance department to make sure that there are at least 25 air exchanges per hour. And there are few companies which have come with the proposal that after the HEPA filter, so number one, that you need to discuss with your maintenance team is 25 cycles of air exchanges per hour. Number two, certification that your HEPA filters are in proper order. Number three, as the air goes outside the HEPA filter before it, now there is a company that has come forward to use ultraviolet rays to irradiate the air that is coming out. So during recirculation, even if a viral particle enters, it is getting completely destroyed. So this is another improvisation that has happened, and they say that they can convert every theater where they can put this facility, and they say that it takes only 8 hours to convert your theater into a more comfortable and sure that the air exchanges are pure and devoid of any viral load. So one of the other challenges that we have had with this COVID-19 virus is the viral load. And the viral load between this and SARS-CoV-1, the previous SARS infection and this one, the SARS-CoV-1 used to multiply, the virus used to multiply in the lower respiratory tract. But unfortunately, in COVID-2, in CoV-2 or COVID-19, it multiplies in the upper respiratory tract, and that's why it becomes such a big threat to the healthcare workers. And I think I've just reached my time, and I try to give a perspective of about the personal protective equipment and the protocol that each one of us have to establish in the center that you're working with. If you are a private practitioner, then you need to really work on the centers that you're going. You need to have a discussion with the maintenance department, the hospital administration, and you need to modify certain practices. And this becomes mandatory to make sure that we protect ourselves, just not the PPE, but also the strategies, the protocols, and decontamination of the theater. I also wanted to say that these particles and the aerosols, majority of them float for about 30 minutes and then they settle down in the floor. And in the floor, they can be there for roughly 2 to 3 hours. So there is a good practice. Then in once we start the OPDs and the areas where the patient move, it is recommended that every 1 hour, we use a 1% sodium hypochlorite solution as a cleaning method. All these areas have to be cleaned continuously, and similarly fomites should be wiped with bacillol wipes or hypochlorite or any of these solution every 1 hour. So such protocols have to be established to make sure that the healthcare workers, the patients themselves, the attenders, and anybody coming to the hospital don't get infected because of the possible potential carriers. Thank you very much for your patient hearing. And now I hand over the mic to Hetal Vadera.
Azam?
Thank you, sir.
Yes.
Yes.
Yeah, Azam, you can start.